low-seated valve, Dr. Salem Assiri. Easy around there.
Slide. It's a little deceiving, you know, it's not really the PVL, it's more of MR and low-seated valve. So my patient is a 72-year-old gentleman, past medical history of diabetes, dyslipidemia, obesity, who came with angina class 2 and New York Heart Association shortness of breath class 2. And this is the ECG, sinus, incomplete left bundle, you know, probably the QRS is like 85 to 90. And this is the echo. You can see clearly the valve is barely opening, and you can see so severe AS, eccentric LVH, and mild PVL. You see the gradient of 42, then area of less than 1, ejection fraction of 45 to 50. Coronary angiography was done at outside hospital. I reviewed it. I actually lost the CD, so I couldn't put it here, but it was clearly non-obstructive CAD, 20-30% here and there. He was referred for SAVR. The patient refused twice, and he's considered for TAVR. So he was actually low risk, and he can go for surgical, but he refused adamantly. He's actually a physician, by the way. This is his CT. You can see the measurements actually pretty good. The annulus area above 600, the LVOT, not much of a calcium. I didn't actually show that, but it wasn't a calcium. Generous SOV, we're talking about 38, 39, and also good STJ height. The left main is relatively low, but the SOV is actually generous. RCA height is 22 millimeter. So straightforward, basically, TAFI. So, you know, this is the trying to get the angiography and then adjusting the valve in the right position. But then during the inflation, you can see that actually I rapid based before this step, and the pressure will go down to 55, 60, and it wouldn't go a lot lower than that, so I aborted. And then the second rapid basing, it went down to 40, 45, so I decided to go ahead and take it. And you can see here that the valve actually dived a little bit while doing the deployment. We tried to pull back, but it did not, so we end up deploying it there. So you can see here that, you know, conical shape, you can see that it's actually 70% in the LVOT, 30% in the aorta. And you can see the shape from the top is actually not that good, but not much of a PVL. So I decided to actually further ballooning. So I post-dilated, and I did even extra step. I pulled the balloon back, and I tried to flare the proximal, the aortic part of it. And you can see this is the final on the right side. You can see the shape of the valve get better, but it's still pretty low, 70% in the LVOT, 30% in the aorta. Then this is the ECG. You can see now it's the left bundle, sinus, really no issues more than that. We did echo. You can see here that this is basically immediately after. You can see the valve is seated low. You can see a very minimal PVL, not much, and also some mild AI, intra-aortic. But you can see also a mild to moderate MR. So we decided actually to stop there because I don't know if we can see. So we decided actually basically the patient is totally asymptomatic at this point. The valve is deployed yet it's slow, so we decided to leave him alone and we took him to the CCU. The next day, this is the echo the next day. Now you can see a severe mitral regurgitation, particularly 2 jets, one central, one posteriorly eccentric, posteriorly directed jet, which is pretty severe. You see the static picture on the right side. And you see here, you see that the AI is getting a little worse. You see a PVL, which is in the posterior. And the most importantly is the MR, which was, before the case was mild at worst. This is the TE. 3D, you can see the leaflet, the anterior leaflet is actually restricted, at least the basal half of it. So, patient is totally asymptomatic, and he was telling me, why you keep coming to my room? So this is like 2 or 3 days post the procedure, totally asymptomatic, no shortness of breath, no issues at all, no further electrical disturbances. So would you leave him alone? Can you actually leave him alone? Is it actually reasonable to leave him alone? Is there any percutaneous option? Or do you have to explain extensively and tell him that there is something went wrong and you have to send him for either percutaneous or surgical fix? So that was the dilemma. So I decided to actually talk to him, talk to his family, and inform him what is going on. And I told him, I think we shouldn't leave you alone. Maybe we should do something, even if we don't feel any symptoms. And I actually took the phone and called the surgeons, and we sent him to surgery electively, I would say 3-4 days after that. And this is what they did. They explanted the valve. They did a repair with incomplete band or ring to the mitral. And this is the final. You can see the anterior leaflets actually moving. It wasn't moving because of the Sabian cell. And you can see there is a mild MR, if any, left, and no AI. And this is 6 months later, the ejection fraction 45 to 50, so basically pretty much the same. Actually, after surgery, it gets even lower than that. But at 6 months, the LV is functioning relatively okay, and there is no regurg, either in the mitral or the aortic. And on that follow-up, he was doing well, no ER visits or hospitalization, asymptomatic. And the take-home message is be humble, complications do happen, act wisely and in a timely manner, heart team input, we get all the stakeholders, inputs in this case, also learn from your mistakes and device glitches. And I don't know if there's anyone who will do a different approach, after implanting the Sabian low.
Dr. Salem. Just one question for Ahmed. Why the surgeon interfered in the mitral? Because the mitral was mechanically affected by the low valve. The mitral was perfect before the implantation of the aortic valve.
So I did really hard with the echo guy, also the one who did the TEE, and I couldn't really appreciate anterior mitral valve perforation or disruption beside the restriction of the movement. But the surgeon, after all, he found out that the leaflet is perforated. That's what he was telling us.
Okay. Great case. Just one thing. Wonderfully managed, to be honest. Going to the room and sending the patient to the surgeon.
Not an easy.
It's not easy decision. I will skip a beat every time going to the patient room. That's really brave and very nicely done by you. One thing I think that coplanar view was the problem for the whole thing. It's not the non-coronary cusp was very high, and you are targeting it, and it was very low actually, and you are targeting it. You are not in a very good view. I think that was the problem that created the whole problem.
Two comments. First, from the transthoracic, when you see the MR is a horizontal, that's not a mild or moderate. This is severe. So it was missed. That was severe MR.
But
from the transthoracic.
Well, to be honest,
that's what.
No, that's fine.
Okay.
Actually, this is not in the cath lab table. This is actually the day 2. We're talking about 12 hours after the procedure.
But when you see it horizontal, which the one you saw in the 4-chamber, apical 4-chamber, it is a horizontal jet of MR. That's severe MR.
It is severe, but actually the surgeon put only annuloplasty ring.
Definitely.
They did put a patch on the leaflet.
No, I'm talking about the immediate
Sure.
But for the TE, clarified it more. The second comment is that we have done 2 cases with low TABI. We manage them with the mitral clip. These 2 patients are elderly, very fragile. Last one was 2 weeks ago in Romania, and he was a physician, by the way, as well, the patient. And the gradient of the mitral valve was 4 in the beginning. When we did the clip, we had the gradient of 2. So the gradient went down with the tear. So this is another way, but it was not a perforation, I have to say. It was because of the distortion of the valve and the impingement of the TAVI on the anterior mitral valve leaflet.
Anthony,
For me, the most difficult thing is talking to the patients and telling him what happened, because, he's feeling nothing. Really, he was ready to go home. And if a sudden I'm telling him now you have to go, complication happened and you have to go for surgery, that wasn't a pleasant, but he took it well.
Thank you very much for the case. You see, there are two types of low-seated TAVI. There is a long frame, which is fine. There is a short frame, which is not fine. And the reason is that the aortic valve is a low pressure, is a high pressure closure, but a low pressure opening. So the moment, every time it opens, it will drag it down. So, and probably if you wait a few days, you will find it in the LV. So, yeah, this is very important, but this is one point. The second point is, because Zakaria mentioned this, it's not all patients with low-lying and restriction of the anterior mitral leaflet are fit for mitral clip. You have to make sure that there is no trauma, which is very important. There is no perforation, and that there is a decent coaptation issue which you can help. I think this is very important. Thanks again.
Actually, the TE people, they telling me that the valves keep going down even further. That was one of the
It's
things.
very well known. Short frame keep migrating to the apex.
You find it in the
the aortic, to the apex. What holds the longer frame is not the inflow, is the aortic portion. So it cannot really pass that stage. But a short frame, in a month or so, you will find it at the apex.
Dr. Faisal,
I think the comment is similar to Mohammed, but I think you did the right thing, Dr. Salem, by not jumping and putting another valve, because the valve position was not stable, and I agree with Dr. Mohammed. Embolization is going to be going to the LV. The mechanism of the MR, I still probably I did not understand it from the TE, but if there is an injury, then as mentioned, Dr. Mohammed, the mitral clip will not be a solution. The most important thing here is the patient is to remember that this, as you mentioned at the beginning, you were trying to convince him surgery first. Now I think going for surgery is not a bad deal for him. You give him the best chance. So thank you.
So that was actually the putting another valve.
Sorry, there is a personal question. If you can answer it, you can
Sure.
say it. The issue was not in coplanar view. I think the issue is that you know that you can master it. You have seen it low, but you said, fine, base, and I will pull it up. Is that true?
Not really. Actually, I wasn't the one who's pulling. I was the one who's inflating. But anyway, just back to Dr. Faisal. Initially we said maybe we should put another valve. But collectively, the whole team, we decided that in the cath lab, there's not much of a PVL, no electrical disturbances beside that left bundle. Let's just leave him alone and see how he does in the next couple of days, But then when I saw the MR, I said, maybe if surgery is possible, then it's better for him.
last comment or question.
Doctor, first I commend you for the professional level. You had to explain to the patient, telling him excellent job. بس comment على موضوع الslaying of that MR. The MR direction is posterior.
Sure.
It's either a restricted posterior leaflet or it's a prolapsed anterior leaflet. Perf would not give that direction. I'm not sure, and if it was perf, then the correction would be patching, not putting a ring. So I think it's probably one of the chordae just popped off, and when this was inflated, and that caused it. That's just an observation.
Sure.
Thank you very much. A personal thank you to you, Dr. Salem. It's a great presentation, and I think you took the appropriate path by stopping the patient from going home and talking to the surgeon, and a real safe, and I think it's at that time was a very difficult decision for you, but you did it appropriately. Thank you very much.
Thank you.